Hi, welcome to the Extra Clinical Podcast. This is the name that I'm going with right now. It's not finalized yet, so you may hear a different name by the time this gets published. Today, I'm very, very excited to welcome my first guest on this podcast, Bob Harrison, MD. Bob, thanks so much for being here.
Thanks, Christian. It's great to be here.
And I think you're a very fitting guest too for this podcast that is about people who started in clinical work and then expanded beyond clinical work, either partially or entirely. Because in my own career, when I was first doing just clinical work, you were one of the first people, I don't know if you remember this, that I made contact with in the non-clinical world.
I do remember that.
I think it was Michael Hodgson, my mentor at OSHA, who knew that when I was doing EIS, I was interested in the CDPH occupational health position. And then he put us in contact. So we've known each other, or we've been in communication with each other for over 4 years now.
Yeah, that's right.
And still also hilariously, the first time we're meeting in person, because when we worked together for 2 years during COVID, nobody was in the office.
Yeah, that was a weird time.
Well, I'm glad we finally got to meet each other. So, as an introduction to who you are and what you're doing now, I'm curious to hear, what do you tell people when they ask you what you do?
I tell people that I'm a doctor that specializes in worker safety and health. The field is called occupational medicine, but I find that a lot of people don't really know what that is, Krishna. So I say, I diagnose and treat people who are hurt on the job, and I figure out ways to prevent their injuries and disease.
Great. Yeah, I've had the same experience as you. I also happen to be an occupational medicine physician by training, and in the beginning, a lot of people, my dad included, thought I was switching to occupational therapy, which is a different thing, although we oftentimes work with occupational therapists. And when I left my original training program, I started in emergency medicine and then left to occupational medicine after my first year. They do like a roast every year at the end of the year, and like the faculty roast the residents and vice versa. And then they roasted me by saying like, oh, Krishna left for occupational medicine. And it was like, some kind of Photoshop photo of me like doing construction or something like that. So people have some idea. They understand the occupational part, but maybe not the medicine part. And then can you describe a little bit more about what your day-to-day work looks like nowadays, and what's that split between clinical work and non-clinical work?
Yeah, I love my job. First of all, I just want to say that I think I have the ideal mix. So a couple of days a week, I diagnose and treat patients who have work-related and environmental exposures, injuries. I teach residents, students, medical students, nursing students. So I'm hands-on. I get to know my patients. I get to follow them over the course of their injuries and their outcomes. And I get to go out to see some of their workplaces. The other part of my week is spent working with the California Department of Public Health. And there I direct a group. I work with a group of epidemiologists, statisticians, industrial hygienists. Those are the folks that go out and take air samples in the workplace, health educators, and we track work-related injuries and diseases in California. So we collect all this information, where workers are injured in the state of California, and then we go out and do health studies. We do investigations, and we publish that all to try to prevent those. So I have my feet in both worlds, which to me has just been an ideal mix throughout my career.
And then nowadays, what roughly is the percentage mix that is clinical versus non-clinical?
I'm seeing patients 2 days a week, and then the non-clinical is 3.
Okay. And then in your case, I think the clinical and non-clinical work, would you say that they're pretty interrelated, that they inform each other?
They totally inform each other on a very personal level. When I'm doing my public health work, I'm actually thinking of real people. I'm thinking of my patients. If I'm reading an epidemiological study and I'm looking at a data point on a figure or in a table, and I'm actually thinking of the patients that I treat 2 days a week. I'm thinking of their stories. I'm thinking of their work that they're describing to me. So it very much is a very rich experiencing patients that informs my public health work. So as I say, I have a great diversity of what I do, but it's really all meshed and integrated together.
Yeah. Occupational medicine does lend itself well to that too, because it's one of the preventive medicine specialties. I think most people who are doing that residency get an MPH as part of it or get one before or after. You said something that I think is very specific to occupational medicine, even outside of the other preventive medicine specialties was visiting workplaces. Could you speak more to that? Because I think that's a really fun part of occupational medicine that other specialties I don't think ever get to do.
So one of the things that I learned and now I teach my residents and students is how to take an occupational history. In other words, asking my patient, what exactly do they do? Describe, let's say if somebody is a machinist and they're working on a part, I'll have them go through the details of what they do, how they machine the part, what chemicals they're exposed to. So I try to imagine what that workplace is like, because key to making a diagnosis in occupational medicine is understanding the exposure. If I go to that workplace, a picture is worth 1,000 words. It leaves an indelible mark that I can then inform my occupational history with my patients. And moreover, it's incredibly fun to go out and actually see what people do. I personally have had an interest probably since I was a kid in how things work, how things are made. And I love going and understanding how do things get to me as a consumer. If I order something or I buy something in the store, how did it get to me? Who made it and how was it made? And then how were workers affected?
Let me guess. Bob Harrison's favorite shows. How was it made? Did you ever see that show?
Yes, exactly.
I don't know if that's still on. I used to be fascinated with that show as a kid. I know you like dirty jobs.
Yes. Oh, absolutely. And in fact, I've been and seen a lot of jobs in the workplace, and I think I want to nominate them for that show.
Yeah. And I'm trying to think, what are other behind the scenes? I mean, all these, there was a period of time when I was in med school where there were so many like food industry documentary style shows. I don't know if you got into those ones, but work kitchens are like pretty dangerous places. There's heat, there's sharps, slippery floors, air quality stuff, which I feel like only recently I'm hearing more people to understand that could be dangerous, indoor air quality.
Yeah, I was out to dinner at a restaurant a couple of weeks ago, Krishna, and I disappeared. And I was literally in the middle of the kitchen because somebody made me the most delicious dessert. And I had to go behind the scenes and wander into the kitchen and find out who it was that made it and how he made it. And the kitchen workers were pretty much, first they were in shock that anybody actually was going back to see what they were doing. But then, in fact, they were really pleased that I cared about who they were and how they made my food. And they smiled and they thanked me. I find that incredibly gratifying when that happens, if I'm in a workplace and I make visual contact, and maybe you could call it almost an emotional contact with somebody. I see you. I see what you do. I value what you do.
That's for sure one of your strengths. That happens to be just like a personality trait of yours. One of the first memories I have of knowing you was, I forget what the case, it was some situation where we were trying to figure out something about people's experience on the job. And I was like thinking very formally and quantitatively about what the questions are going to be and how to be consistent, blah, blah, blah. And then I thought about it for a long time. And then I called you and you were like, oh yeah, I just called somebody. I just
Right.
picked one of the numbers, called them and talked to them for 20 minutes and got like way more information than I had just like trying to think about it on my own. So I think that's a great skill to have. I would like to be more pick up the phone. I feel like it's hard to pick up the phone nowadays.
Well, I think it's part of being a physician, quite honestly. That is a trait that I hope we all value, which is listening. So I listen, obviously, is part of my specialty. I listen to what somebody tells me about what they do. And that makes me a better diagnostician. I can then suggest some solutions that will help them prevent some exposure that they're having in the workplace. I can build up that trust. There's a lot of reasons why workers, patients might be reluctant or afraid of relating something that happens in the workplace. And we can talk a little bit more about that if you'd like. But it's essentially respecting and listening, which is what we should all be doing as doctors.
Yeah. This is the last thing I'll say about occupational medicine. So this doesn't become, I think you and I like occupational medicine too much. This is becoming like an advertisement for occupational medicine training. But also striking that, previously working in the emergency room, I never asked people what they do for a living, but that people spend a lot of their lives at a workplace. And so a lot of exposures just gives you a sense for a lot of things that are likely their income or their education level. Uh, yeah, it just reveals so much about them, just knowing what they do. And like you're saying, it helps build rapport, helps build a connection when people can teach you something if you're genuinely curious about what they're doing. Because most of the time when I was seeing patients that worked in industry, they would talk about pieces. Well, the lug nut goes into, where the rig pulls up on the and I'm just like, I have no idea. Can you draw it for me? And then patients would usually be excited to like Google image search whatever they were talking about and show me, and then that'd give me a good sense.
Yeah.
Okay, so now that we have a sense for where you're at now, I'm really curious to hear about the beginning. Like, what motivated you to go to medical school?
I was a history major in college. Love history, still do. It actually informs my work in occupational medicine quite a bit. I like to know why things are the way they are when I look at them in a workplace or my patient tells me their work is organized in a certain way. And that's historical. Sometimes it's political, sometimes it's economic. But I was a history major in college and I focused on the beginnings of the Industrial Revolution in the United States. That's around 1890, 1910. Workers were coming from the farm, small businesses, into very large factories. And they were getting hurt by the hundreds of thousands, sometimes incredibly seriously. And so I knew about that when I was studying history. I was pre-med, Krishna, and I was either going to go be a history professor, get a PhD, or I was going to go to medical school. And I'm grateful for my father, who, like any good practical father, said, "I think there's better jobs in medicine." So I went to medical school, not knowing anything about occupational medicine when I entered medical school.
What did your parents do for a living?
My father was a garment salesperson turned middle school science teacher. Tried to be a physician in the 1930s, applied to American medical schools, was not able to get in, went to Europe for a year, failed over there, came back, but he deeply loved science, so he gave me that love for math and science. My mother was a college professor, and also, very much focused on education. So that was, imbued from day one. But I think it was probably, I credit my father most deeply for the love of math and science from the time that I was 7 or 8 years old. So he very much encouraged me to pursue medicine. I was very grateful when in my first year of medical school, I was sitting, I think it was the first month, in a mandatory class on what was called community medicine. We would now know it as the social determinants of health or preventive medicine. But it was essentially the factors that cause disease and disability: nutrition, obesity, class, income, environment. And we had a lecture on occupation from a very charismatic labor union leader who basically came into my class and spoke to us, thought he was speaking to me, and said, "We need healthcare professionals, we need doctors to help frontline workers in chemical factories who are getting poisoned by toxic chemicals." And so I spent my summer working with that union after medical school, driving out to New Jersey to a chemical factory where workers had hepatitis that was caused by a chlorinated solvent they were exposed to at this chemical factory. They didn't know anything about the chemical or its connection to the liver. I felt like I was discovering or uncovering something for them. Wrote a lengthy report, gave it to them at the end of the summer, formed close personal bonds with the union members that I was with. And that was it. I said, "This is amazing." They appreciated me, the expertise that I could bring, and I felt I could make a difference.
So that class was in med school, you said?
That class was in med school. So, Krishna, I'm probably one of the few doctors in the United States who heard about occupational medicine in medical school.
Yeah. And so you were, but still, even before that in college, when you were interested in history, you just happened to be interested in industrial history?
Yes, I was interested in industrial history. I was interested in the roots of factory work in the United States, the economic and political forces. I was very interested in labor unions and collective organizing, the power relationships between labor and management. It's what we would now call capitalism. Was the area that I really got interested in.
Okay, so I'm already seeing the perfect storm for an occupational medicine physician to emerge. And then so then when you were in med school, did you have a sense for what you were gonna, what did you do after med school?
So during med school, after this summer experience, I did some volunteer work, worked in some occupational medicine clinics in New York City, did some field work in research and environmental medicine. And then after medical school, I knew I wanted to enter this career that was called something like occupational medicine. Didn't know really what it was or the pathway. So I trained in internal medicine because I also love seeing patients. Thought that internal medicine was a good grounding to be able to do occupational medicine because these, after all, are adults primarily, although there's some children, there's some take-home exposures from the workplace, but primarily adults, internal medicine. And then, honestly, after I finished my internal medicine, that was at UC San Francisco, I was going to go and get a master's in public health to be more grounded in epidemiology, biostatistics. When this new residency program came along, and I was offered a position that was going to entail 2 years, which included the MPH and an additional year. That would lead to board certification in this specialty. And I grabbed that. It was, a perfect opportunity at the time.
Where was the OCMED program at?
That was at UC San Francisco also. So it was one of the earliest programs. There are now 19 of those programs around the country. UCSF, I think, was about the third or fourth to be established.
And so did it get established while you were doing internal medicine training?
Exactly.
Come on, that's 3 in a row. 3 like coincident,
Yeah.
almost coincidences happened that landed you here.
I'm fortunate, but I also, I think had a good nose, a good sense of how to find outstanding mentors and see where those doors and opportunities were opening.
Yeah. And you mentioned an important point for anybody who's interested in preventive medicine residency, including occupational medicine, which is you get a degree for free. That's a good deal. You get an MPH, not only for free, actually, they pay you a resident salary. Well, I don't know if they did when you trained, but when I trained, I got paid to get an MPH, which was pretty good.
Well, I didn't mention that, Krishna, actually. I was going to go and get my MPH and pay for it when this opportunity came along, and I said, that was a good deal.
And then, okay, so then you did occupational medicine residency, and then what was your first gig after you did that, or was there any other postgraduate training you did?
No, I came out of that residency training, and then I was immediately brought on as a junior faculty at UC San Francisco. This was in 1984, and there was not a clinic, there was not a practice at our university where if somebody was hurt or had exposure to a chemical and they needed a doctor who was at UCSF, there was no one. And so that was me. I was hired to be the person to start a clinic, a practice, so that if a patient, a worker needed to be referred, there was somebody to see. So I started the occupational medicine practice, and it's grown. And 40 years later, I'm still there, but with, from 3 staff to we have about 25 or 30.
Wow. And then who Do you get a majority of your patients from particular industries?
All over. They come from, semiconductor tech, biotech, some agricultural workers from the surrounding counties, excuse me, warehouse machinists, painters, a whole variety of different companies referred either by families or by coworkers or because they're looking themselves for a second opinion from other specialists at UCSF or in the broader community, sometimes from their lawyers if they're involved in a workers' compensation claim.
One of the interesting things about occupational medicine is that there tend to be regional flavors depending on what the local industry is. And it's fun to compare notes about what all it's like to treat a certain type of patient. When I was in Houston, we had, well, actually, I don't know, maybe there's linemen everywhere. We had a lot of linemen, or maybe it's just a dangerous job. So they ended up in my clinic a lot. And we had did you ever hear of the air conditioner company?
Carrier?
No, Daikin, is it called?
Yeah, Daikin. Uh-huh.
And so they had a factory just outside of Houston, and these like assembly line workers, they have a lot of repetitive stress injuries, and it's a crazy job to think that it's one of these jobs where you don't think they still have humans doing it, but they do, and it's stressful, musculoskeletally, and so that was like a lot of what I saw. And so in talking about like chip workers, that feels like a very Bay Area industry. At anything any particular occupational hazards or injuries that you tend to see in that population?
Well, when I first started the practice here in the early 1980s, there were a lot of chlorinated hydrocarbon solvents. Semiconductor manufacturing is very chemically intense. It seems like it should be putting in air quotes here clean because you have to produce these in clean rooms so there's no contaminant or dust that gets in these semiconductor chips. But it entails a lot of sometimes pretty exotic toxic chemicals. And at that time, there was hydrogen fluoride or hydrofluoric acid, what are called glycol ethers, which we discovered were reproductive hazards, fortunately have been largely phased out. Chlorinated solvents like trichloroethylene, which is used as a degreasing agent. And then a whole host of exotic chemicals that honestly no one really knew very much about. There wasn't really very much toxicology, so workers would come to me. I'd have to do a lot of basic research on them.
When you left, do you ever miss internal medicine? Like being an internist?
I still think like an internist.
Okay.
I don't know if anybody who is trained in internal medicine ever gives up perhaps thinking like an internist. I miss keeping up with internal medicine, which honestly, if somebody came to me with, what is the latest treatment for diabetes or hypertension, I might have to look that up. But I still could look it up, and I could still probably make a really good judgment about it. Short answer is no. I don't miss internal medicine. I think it's because I still think like an internist.
I'm completely with you. I think in the beginning when I was leaving emergency medicine, I was very worried. I'm not going to have the skill set. I'm not going to know off the top of my head what the clinical decision tool for, getting a CT angiogram or whatever is, but we could look it up. I mean, that's the benefit of having cell phones and the internet is that we don't need to know everything right away. I don't know how much this question will apply to your career because you had known for a long time and had like taken the right formal steps to end up in occupational medicine to be like very well suited to that and the public health work. But I think a lot of people, a lot of professions are susceptible to this, but I think especially clinicians, we're given a path and we're told you need to be, board certified in order to be allowed to do this specialty. If you want to do something else, if you want to explore other options, you kind of have to start from go again and redo training. But that's not the case. Like once you leave clinical medicine, you realize nobody's checking your licensure for things. It's just a matter of whether you want to do the work, whether you're interested in it. Had there ever been a time in your career where you felt imposter syndrome, you were doing the work and didn't feel like you were qualified to do it for some reason, and were sort of like worried that people might find out that you didn't know what you were doing?
No, I have to say, I guess I can tell you an anecdote. Sometimes I'll do some testifying for a complicated case, some toxic exposure, and the worker has a workers' compensation or a lawsuit against a chemical manufacturer. And I'll sometimes be asked by the lawyer, well, Dr. Harrison, and let's say this is a cancer case. Somebody is exposed to a toxic chemical, and I've made the connection between that toxic exposure and their cancer. And I'll be asked, Dr. Harrison, so you're not an oncologist, are you? And I'll say, no. Dr. Harrison, you're not board certified in hematologist, are you? No. Dr. Harrison, you're not, you don't have a PhD in epidemiology. That's right. No. And this will continue and continue. And in an attempt to give me imposter syndrome, Krishna.
Yeah.
But then I realize that what I do is uniquely make the connection and understand the chemical exposure and the disease, which all those other specialists get very little training in. The average amount of education that a medical student has about occupational and environmental health is about 2 hours in their medical career. Your listeners may go back and try to remember a lecture that they had about occupational or environmental health, and they may remember, oh, I heard something about asbestos.
Yeah.
And that was during my first year class on pulmonary disease. And I remember somebody had some slide up there that said, yeah, asbestos, and it caused asbestosis or lung cancer. Mesothelioma, if they could remember that. But that's basically it. So I don't think I ever have had imposter syndrome because what I do feels uniquely interesting and important and different.
Do you consider yourself a generalist or a specialist?
I'm a specialist. I understand the connection between what people do at work and the health problems that they get.
I appreciate that answer. I think something that I struggle with in like, even before we started recording, I was describing to you my current role in public health, and a lot of people in local public health positions have like a mandated function. Like a local health jurisdiction needs to have a communicable disease controller, needs to have a TB controller, STI controller, whatever, and they have a formal title. And I don't have something like that. It's sort of a combination of different things and needs, and it's dynamic and it changes over time. And I am trying to reframe, not that there's anything wrong with being a generalist, but that can be considered, I think, a specialty. That is a particular skill to be able to navigate between different things and liaise between different disciplines. And it's obviously needed.
Yeah, I think that's a specialty.
Actually, another thing that brings to mind in emergency medicine, you know, you ever hear the expression that like the jack of all trades, master of none?
Yes.
And people have said that about emergency medicine providers before, and they don't like that because it makes them sound like unskilled or, like anybody can do it. And the people, I think, often treat emergency medicine people that way, like that's just the sorting area, and then the real specialist will take over. And I had somebody one time made an argument that made a lot of sense to me, which is emergency medicine people, they're resuscitationists. Like they do have a specialty and they do a bunch of other stuff, which I appreciated.
If I go to an emergency room with chest pain, I want to see a specialist.
But
The emergency room doctor who's going to be able to immediately diagnose and treat my chest pain before the cardiologist gets there.
and
That's
so,
the specialist I want when I show into the ER.
and so what do you remember what year emergency medicine became a specialty?
I don't.
I think it was in the 80s. It was like pretty close. So like before that, I think they just had like I don't know who was working in the emergency room. I think they just had interns or someone working there, or that was part of like I don't know if it's different. I'm sure it's different in India. My father, when he's a physician, and when he was first training, he was called a house officer, and they were just like running the first year trainees were just like running the ED like and they talk about it like, oh, it was such good experience, like that's how you learn how to be a doctor, is like you go in there, you do it. But also a lot of people probably died that didn't need to die because they didn't have emergency medicine specialists there.
Let me tell you about a case.
Yeah, please.
This illustrates the question. Um, I was referred a man who had numbness and tingling from his toes to about his waist and his fingers to his elbows. So he was diagnosed by his neurologist with a polyneuropathy, had nerve conduction studies that showed a sensory motor neuropathy. He was treated with high dose steroids for what the neurologist thought was some sort of autoimmune, idiopathic, fell into this, we're not really sure, but we think it's immune mediated. Felt terrible on his high dose prednisone, gained a bunch of weight, had some myopathy from the prednisone that was on top of his polyneuropathy. Finally, the neurologist asked him what he did. And he said, I work as a mechanic in an auto body shop. So the neurologist, rightly so, said, oh, there must be some chemicals there. Mechanic, I've taken my car in for car repair. I remember there's a bunch of chemicals, and referred him to me. And my first question when he called to make the appointment is, right, what is the chemical that you're working with? He said, well, I use a lot of this spray degreaser. Now, I happen to know what a spray degreaser is. Among other reasons, I've done my own mechanical work on my car, and I've been in auto stores on many occasions, browsing the aisles, looking for degreasers myself. I said, bring me the can. So he brings me the can, and I read the label, and I made the diagnosis. It had 60% N-hexane. And that was one of my, that was one of my aha moments in occupational medicine. Was one of those OMG, although I probably said something that I can't repeat on the air here.
Yeah.
You know what the next thing is that I did? I went to the auto supply store after work, and I looked for that degreaser, and I found 6 products that had N-hexane in it. Now, N-hexane had been discovered about 3 decades earlier to cause severe peripheral neuropathy. And I said to myself, what is that doing on the store shelves, right? And the next question is, how many other mechanics have peripheral neuropathy that have been considered idiopathic by their primary or their neurologist? Probably lots, right? Because anybody could buy it. Fast forward about a year, and working at the state health department in that capacity, with my colleagues, I put out an alert. We sent it to 10,000 auto repair shops. We said, don't work with these products that have N-hexane in it. And 6 months later, the industry had completely removed N-hexane from all of those products, and have not seen another case.
That's awesome. And that's such a good example of how the clinical work informs the public health work. And then maybe even vice versa, if that alert goes out to physicians, then they are now aware that's on their differential.
Exactly. So, getting, simply just taking an occupational history. And what I say is, if you, see something, say something, and it could be just as simple as referring to an occupational medicine doc who can go take a deeper dive like I did, or calling up your local health department or the state health department and saying, I've just seen somebody who was exposed to this toxic chemical. There could be dozens of other people in the workplace. Some investigation needs to be done.
This is making me think, acknowledging that there's always opportunity costs, there's always trade-offs. Do you think there's room? Do you think it would improve healthcare, public health, for more physicians to have a foot in public health work?
I think it would absolutely improve our clinical care and the prevention of disease and disability in our population if we had a better integration of our clinical work with the public health system, so that frontline healthcare providers could at least know if they saw something or they saw a pattern in their practice, who they could talk to. I'm a great believer in mixing disciplines, um, getting lectures for people in practice. I give these all the time, Krishna. For example, we just lowered the acceptable level of blood leads in California. We had a 50-year-old standard that said if your blood lead was 50 or greater, 50 micrograms per deciliter, that worker, your patient, has to be removed from their workplace until it drops to 30. We have now lowered that to, if it's 30, they need to be removed until it gets to 20. So it's about half. But in fact, the public health level of concern is really 10. So we're now launching a big public education for healthcare providers in California to reset their understanding. So instead of reading a lab slip that says, 50, you do something. If you see a blood lead of 10 or greater, you do something. Now, what should the physician do if they have a patient with a blood lead of 13, right? They should report it to a local county, because if there's a patient with a blood lead of 13, there might be 5 other people in that same workplace.
So since you have historical context, I'm curious how much safer are workplaces now than at the start of the Industrial Revolution?
They're a lot safer. Yeah, I mean, good thing they're a lot safer, right? It took a very long time. One of the big factors was in 1970, we passed the Occupational Safety and Health Act, the OSHA Act. It created OSHA. Before that, there was no regulatory agency. There were no enforceable standards to keep workers safe.
You said that was in 1960?
1970.
That's pretty late.
It's pretty late.
There was no OSHA before that?
There
Wow.
was no OSHA. Yeah, there was no OSHA for about the first 100 years
Jeez.
after the start of the American Industrial Revolution. And so since OSHA was passed in the 1970s, we have a lot of better regulations, a lot better enforcement. We have a mechanism for workers to file an OSHA complaint, to get a government inspector. That being said, we have in California over 1 million workplaces. We only have about 200 OSHA inspectors. So they obviously can't get to every workplace. But we have standards covering a lot of this. And that's made workplaces a lot safer. We have a lot more work that needs to be done. A lot more areas of repetitive injury, what we call ergonomic hazards, new problem of artificial stone, the stone countertops that are causing a big epidemic of silicosis, to grind and polish and cut high silicon containing materials. So we're still seeing some of these very old diseases even today, when we've known about them for hundreds of years.
Yeah. Is your sense that occupational safety hazards, like history repeats itself with that? Like as new industries evolve, sort of there's a feeling out period where there's a risk and then it needs to be demonstrated. There's some kind of argument between workers' rights and employers' rights, and then hopefully safety improves.
I say the biggest change that one of the biggest changes that I see that impact my practice and my career is the changing nature of work. We have a lot of workers in the informal workforce, what we would call the gig economy, or they're contract workers, they're temporary workers. The number of workers who are in labor unions have declined dramatically over the last 50 years. And many of these workers are either afraid or don't know how to speak up, or if they see something really hazardous, file an OSHA complaint. There's a lot of backgrounds, cultures, languages that have emerged, particularly in California. And so that's really, I think, one of the most challenging parts that impact my work is, as I collaborate and work with, let me just say briefly that I do a lot of research and studies. And I always say those studies are only as good as the people who can take that information and do something with it. I can publish something, Krishna, and it may be the most important research in the world that has to do with improving worker safety. But if it's not taken up by companies or workers to do something about it, then nothing changes. And so that's really the challenge that remains and will always remain, which is why I never have a dull day.
If you could do anything different about your career, would you have changed anything?
It's a great question. No, I wouldn't change a single thing, actually.
Yeah.
I can't think.
That seems to be the theme of this.
Yeah, there has never been a dull moment. There's just an seeming unending series of interesting challenges. We were just talking before this interview about H5N1, for example, and the interplay between food safety and worker safety. We have a lot of dairy farmers. We have a lot of dairy farms. We're the biggest dairy state. We have many, many dairy workers in California. Reaching those workers, protecting them, is now another interesting challenge. I never would have thought of that 2 years ago if you'd said, would I be thinking about dairy workers and what a milker is? And do you get H5N1 because it gets sprayed in the air and lands on your eye? Or is it air transmissible? And we should give workers N95s to protect them. And what is the scientific evidence? And if I hand out an N95, is a worker even going to wear it? And if they don't want to wear it, why not? And how do I get them to doctors to get tested?
Yeah, I think this is reminding me about why you're such a good fit for occupational medicine too, because you have to want to learn all the time because it's too multidisciplinary. It's even just within the biomedical perspective, right? It's maybe people think it's just musculoskeletal, but it's also toxicology, but it's also pulmonary and cardiovascular and infectious disease. And it's also kind of One Health that you're talking about. People in
Yes.
industries are in contact with the environment and with animals. And then it's also political. There's ways to pass policy that protect worker health. There's behavioral. How can we get people to wear the PPE and understand the importance of safety, clock in, clock out, whatever these safety procedures are. There's so much stuff. And if you like to learn, then I think occupational medicine, you can keep learning. I mean, do you sense that you're learning at a similar rate as you did 20 years ago?
Oh, absolutely. As long as it's still going in, Krishna.
Yeah.
I mean, at one minute I'm talking to a virologist to explain to me what a clade is related to H5N1.
Yeah.
The difference between a clade and what is the other, not the genome, but there's another term that the virologists are using.
Virome? I don't know.
Virome, yeah, it's a way that we're tracking the genetic variation in H5N1, which is a determinant of infectious risk to the dairy worker. So 1 minute I'm reading the literature to try to understand virology, which has advanced tremendously. And then the next minute, talking to my colleague in industrial hygiene and asking her, well, do you think an N95 respirator is an effective tool to protect a dairy worker from getting infected? And then the next minute, I could be asking a community advocate who's working with dairy farmers what the dairy workers really care about.
Yeah.
I mean, I could think I should give him an N95, but if they don't want to wear it for whatever reason, I need to understand that because the effectiveness of my public health intervention is going to depend on all these factors.
Again, at the risk of sounding like a commercial for occupational medicine, do you agree or disagree with my take that occupational medicine is the most underrated specialty?
It's a little secret field. I can't agree. That's what I tell people that apply. Very high job satisfaction, by the way, very little burnout. You know, on the ranking of medical specialties is consistently up towards the top of highest satisfaction field. So I always say it's a field that nobody's ever heard of, but you find it, and it really has a very high happiness quotient.
I don't understand how it's not ultra competitive because I think even when I was applying in 2016, my the the program director for the occupational medicine program I was coming into was almost like gut checking me to be like, there's a decreasing number of these special, like these residencies are closing down. I don't know if that's still the case or if they're making new ones. I don't know how it's not super popular for anybody who is in family medicine or in internal medicine who has an interest in improving their quality, even if it's just for the purpose of improving their quality of life, or they work for 5 years being an internist or family medicine physician and they want to keep learning. They want to do more besides be in the clinic. I always found it depressing to be in a clinic all day. Even just the possibility, the potentially going out into the workplace and seeing what people are doing in the real world was always like so appealing to me.
Yeah, I think it's a great way to add some variety to a career. I mean, I think there's been concern among many of the specialties about burnout, and I say this is one option to take a look at, the preventive medicine or occupational medicine field, because I don't see any of my residents or alumni who are now working. I don't see any of them burned out.
So if somebody came to you who was involved strictly in clinical stuff and they were interested in moving beyond just clinical stuff, any advice you would give them for how to explore what's out there?
So I I I talk to a lot of people who ask me this advice, Krishna, and I say, start reading, start going to rounds, start going to lectures. You know, for example, we have occupational medicine rounds twice a month at UCSF. Sign up, start to come, start to talk to our faculty. I think getting an MPH is probably a good career pathway. It's not absolutely essential to getting into the field, but I think it's a really good introduction. There are preventive medicine and occupational medicine residency programs that are 2 years, all of which include getting an MPH. So as we started out, that's a pretty nice deal to combine those two together. It's not absolutely necessary to enter another residency, but I think it's probably helpful. That is a big decision if you're out working already. You know, for many people, well, I'm going to go back and I'm going to be a resident for 2 years. You know, it's a financial hit because you're going to go from a real salary to a resident salary. I think it's personally worth it in the long run.
And since you are interested in the history of things, I think somewhere maybe I had a bad experience with history in high school. I sort of had not paid a lot of attention, had not spent a lot of time reading nonfiction. Now I'm suddenly getting into it again because it keeps happening at, I guess, in regular life, but especially at work. Something happens, nobody knows what to do, and I'm like, for sure there's precedent. For sure something similar to this has happened before, and we can probably learn from finding whatever references, reports, or narratives that have been written about it. Do you have any top recommendations for books about either medical history or public history, public health history?
Well, I think maybe because I've just finished up a study about the workers that make our food in chicken and pork processing plants. They bring our chicken, our white meat, that nice hand-cut fillets, the bacon that we buy. So I went back and reread The Jungle by Upton Sinclair, which I don't know. I think I read when I was in high school, but barely remembered and didn't have the same context it does now. But it's a tremendous book about working conditions in the Chicago stockyards.
Great. Classic. Well, thanks so much, Bob. I appreciate you being my first guest on the podcast. I think there's a lot of great advice here for people that are interested, not just in occupational health and public health, but in extra clinical work in general. So thanks for listening, and catch us again next episode.
Thanks, Christian.